Hello everyone, welcome to this video where we will be discussing the dermatology recall questions asked in the just conducted FMGE July 23 exam. All of you who have given the exam will agree that this was not an FMG exam. It was almost similar to sitting for a Neet PG exam. Very high quality questions, concepts, clinical cases, and nice images that were asked in the exam. So for all of you who have given it, I sincerely hope that you all get the best result. It's just a few days away and I see you on the other side. And for those who are still preparing, who are yet to give the exam, please stay away from one-liners and rote-based reading. No, this is a time you have a few months still there. So this is a time to read well, study the subject, form your concepts and understand what you are studying. Okay, because now the exam is just only assessing your understanding of what you have read. So it's time to understand, to form our foundation, because not just it will help us clear the exam, it will also help you all become very good doctors. And like every recall video that I do, in this one also, I'm very happy to say that every question that was asked was discussed in the classes, whether it be regular classes or the rapid revision or the various tests that we conduct. There was nothing that was from outside. So for all my students, I am sure you got 10 on 10 in dermatology. And for the ones who are yet to give the exam, be very thorough with what we are discussing. And I'll reiterate the importance of PYQs. In this exam also, almost all questions have been discussed in the class. Why do I say almost all? Because the topics are the same. The previous year's question topics are the same. It is just that they have turned, twisted or changed the language somewhere here or there. But the basic essence, the basic topics are still the same. So you may not see exact same repeat, but you will see the same repeat topics. Now, starting with question number 1 here, a 50-year-old man presented with skin lesions as shown in the image. On examination, painful swollen fingers were noted along with an inflamed wrist joint. What is the most likely diagnosis? So the question here is telling us that the patient is having skin involvement as well as swollen fingers, inflamed wrist joint, which means the patient is suffering from arthritis. So here we have skin involvement along with arthritis. Now let us see what is there in the skin. In the skin, here image shows you multiple red plaques which have silvery white scaling on them. So in the image here, you see red plaques with silvery white scaling. Along with that, there are some changes that can also be noticed in the nails. So here the patient has red scaly lesions on the fingers along with nail involvement. And he has arthritis. Now let us look at the options. There is reactive arthritis, psoriatic arthritis, osteoarthritis and pseudo-gout. Pseudo-gout is a type of arthritis where there is deposition of calcium pyrophosphate crystals in the joint, which leads to sudden onset redness and swelling of the joint. This is not associated with skin lesions. So pseudo-gout is out. That sounds good. Osteoarthritis in the elderly patients, again, it's a very different kind of involvement. There are no skin lesions. This is also out. Now we have to choose between reactive arthritis and psoriatic arthritis. Both of these show skin plus joint involvement. Now, in reactive arthritis, there will be number 1, history of an infection prior to onset of arthritis. That infection could be a GI dysentery or it could be a non-gonococcal urethritis. So there will be a history of infection prior to onset of the arthritis. Along with this, the patient will present with a typical triad of conjunctivitis, urethritis, arthritis, and the skin lesions will come after arthritis. So even though the patient may come to you with both of them, but it will be skin plus arthritis coming at almost the same time. On the other hand, the option of psoriatic arthritis, here you will have typically psoriatic lesions with arthritis. And these psoriatic lesions will be present prior to onset of arthritis. So you have the typical red scaly lesions of psoriasis along with the typical arthritis. So what is the correct answer to this question? Yes, I know you all have understood it now. The correct answer is option B, that is psoriatic arthritis. Because number one, the typical lesions of psoriasis are present in this patient, red scaly, well-defined papules and plaques. Secondly, the involvement as mentioned in the text, the swollen fingers, the wrist, these are all typical sites of psoriatic arthritis. So yes, we come to the correct answer here. That is option B, psoriatic arthritis. Coming into a little detail about psoriatic arthritis, this is a seronegative spondyloarthropathy with increased chances of finding HLA-B27 positivity. Here, in 70% of the patients, psoriasis is present before the onset of the arthritis. Another 20% will have it together. So majorly in 90% of your patients will present with skin as well as joint involvement. On the skin, you will see these typical red scaly, well-defined lesions of psoriasis. The scaling is silvery white micaceous scaling, and it is very difficult to miss out on these very typical lesions of psoriasis in the image. Then the patients will have nail involvement. When you examine the nails, the most common sign that you see is pitting, and the most specific sign in psoriasis is the salmon patch or the oil drop sign. So the patient will come to you with skin involvement and nail involvement. Now, when you see the joints, the most common joint involved is the DIP. How to remember? Psoriasis has nail involvement. So under the nail, what is the joint? It is the DIP which is present near the nail. So the most common joint involved in psoriasis is the distal interphalangeal joint. Now, when the distal interphalangeal joints are involved, there will be swelling, there will be redness. That swelling, when it involves the fingers, can lead to swollen fingers. Now, these swollen fingers look like a sausage. So these are also called as sausage digits. Very typical of psoriatic arthritis is dactylitis, which is just swollen fingers, and these look like sausage digits. Of course, there can be other joints that can be involved, wrist joint, knee joint, ankle joint. All of these can be involved in psoriatic arthritis. Then there can be tendinitis, most typically of the Achilles tendon in the heel. So these are all classic findings of psoriasis. Now, in 2021 December exam, there was a question in the FMGE exam which said, a patient presented with lesions as shown in the image below. He also suffers from psoriatic arthritis. What is the drug of choice? The image showed this kind of an image where there were red scaly patches over the back, telling you that the patient suffered from psoriasis and psoriatic arthritis was given in the question. So when a patient suffers from psoriasis with psoriatic arthritis, what is the drug of choice? That is methotrexate. So the drug of choice in such a patient is methotrexate. So see, this was a question asked in a little different form in the 2-year-old exam. So that's what I'm telling you. These are all same topics. They will not go anywhere outside of dermatology to ask you. Whatever we are discussing here can be asked in your exam, and I promise you there will be nothing from outside. So just focus thoroughly on the questions that we discuss. So what is the drug of choice? It is methotrexate. So when we do X-ray in psoriatic arthritis, in early disease, we see typical fluffy periostitis, very typical of early psoriatic arthritis. And later in the disease, when there is excessive damage even to the underlying bones and the joints, what we see is this typical deformity which is called as pencil in cup deformity. Here, when you look at the middle phalanx, in the middle phalanx, there is a osteolysis which leads to a pointed appearance of the bone. So this looks like a pencil. And when you look at the distal phalanx, it becomes concave. So this looks like a pencil in cup deformity seen in the later stages of the disease. A very typical finding on radiology. Now, what was the other option? Reactive arthritis, which we had to rule out. See, reactive arthritis is a type of arthritis which develops after an infection. Now, this infection can be of the gastrointestinal tract. There could be an episode of dysentery after which it develops, or after non-gonococcal urethritis caused by chlamydia trachomatis. The typical triad is conjunctivitis, urethritis, and arthritis. And generally, the skin lesions develop after the onset of arthritis. What are the typical skin lesions here? On the palms and the soles, we see these typical scaly plaques on the palms and soles. This is called as keratoderma blenorhegicum. Very typical findings on the skin. On the palms and soles, you see keratoderma blenorhegicum. Then on the penis, there are ring-shaped inflammatory lesions on the penis. This is called as circinate balanitis. So the typical skin lesions that you need to remember in reactive arthritis include keratoderma blenorhegicum and circinate balanitis. Again, this is very different from the image that was given in the exam. Now, coming to the next question. Trichotillomania is associated with trichophagia. In excessive conditions, it can lead to trichobaziar, malnutrition, anagen effluvium, and alopecia areata. First, let us see what is trichotillomania. Trichotillomania is a condition where the patient pulls out their own hair. It's a psychiatric condition. See here first. So this is a psychiatric condition where the patient pulls out their own hair. In terms of classification, it belongs to the group of obsessive compulsive disorders. So when the patient is pulling out their own hair, what will happen? They will keep pulling out. So there will become a patch which will have a bizarre shape and an irregular margin because you don't really know from where you're pulling out the hair. So it will be bizarre shaped with irregular margins. There'll be broken hair of different lengths because when you pull out, the hair is not going to break always at the surface. It is not always going to come out of the root. It can break at different levels. So we see broken hair of different lengths. And due to the trauma of pulling out the hair, sometimes we also see perifollicular hemorrhages. So this is what is trichotillomania. The patient is pulling out their own hair. And sometimes in these patients, there can be a further psychiatric disorder which can lead them to eat their own hair. And this is called as trichophagia. Phagia means eating. So the patient is eating their own hair. Now, can the hair be digested in the GIT? No. So if you keep eating the hair, they are going to accumulate at some point in the GIT. So when the hair accumulates, it can form a ball-like accumulation of the hair. This is called as trichobaziar. So when the patient eats the hair, it can sometimes accumulate in the intestines and lead to a condition which is called as trichobaziar. Of course, these patients suffer from a psychiatric disorder. They may not eat well. They may suffer from malnutrition. But the typical finding is trichobaziar. Anagen effluvium and alopecia areata, completely different, nowhere associated with trichotillomania. Now, just see how trichobaziar looks like. Trichophagia is eating the own hair. And when you eat it, it will accumulate like this in the GIT. And sometimes it can become so big that the patient can present with symptoms of intestinal obstruction. And that is mostly how it is diagnosed also. So when such a big clump of hair is present in the GIT, of course, the patient can present to us with intestinal obstruction. Now, coming to treatment, trichobaziar will of course require an endoscopic or a surgical removal. About trichotillomania, how do you treat? Treatment of choice for trichotillomania is a psychiatric treatment called as cognitive behavior therapy. If you have to give medicines, the drug of choice are selective serotonin reuptake inhibitors. Now, coming to question number 3. A patient presented with itchy lesions and he applied steroids on it. What is the diagnosis? So number 1, the question is giving us a hint that the patient has itchy lesions, and number 2, they have applied steroids on it. When you look at the image, what do you see? In the image, you see that there is a well to ill-defined red plaque. In that red plaque, there is an area which shows a slightly annular pattern or a ring-shaped pattern. Then there are some papules or pustules present within the lesion, and mostly it is hyperpigmented. So what do you see? You see that in some areas there is a ring-shaped lesion, but you don't see typical features of tinea here. So an itchy ring-shaped lesion we all know can be tinea, but it is not showing typical features of tinea. Maybe it is because the patient is applying steroids on it. So does it look like tinea corporis? Typical features I can't identify. I can't call it tinea corporis. Again, even if it was in the groin, could I have called it as tinea cruris? No, because I can't see all typical features. So what do you call it? You call it a tinea incognito. Since you can't identify it properly, you can't make a confirmative diagnosis, you call it as incognito. Why so? Because the patient is applying steroids on it, which modify the clinical picture. Now, look at how a typical tinea will look like. When you have a dermatophytic infection, most commonly with Trichophyton rubrum, it is called as tinea. Now, tinea, when a typical lesion you see looks like a red ring-shaped plaque. That is why it is also called as ringworm, because it is a red ring-shaped or an annular plaque with central clearing. On the surface of it, you typically see vesicles, pustules, and a lot of scaling. And the lesion is classically itchy. So these are the typical features of tinea, a red ring-shaped plaque with scalings, pustules, and itching. Now, this is due to host inflammatory response. If the patient applies steroids on it, that is obviously not the correct treatment. But if you apply steroids on it, steroids are immunosuppressives. They will reduce the redness, reduce the itching, scaling. So this will all subside for the time that the patient is applying steroids. In that case, you will get this kind of a clinical picture where you can make out a few features, but since it's modified, it's difficult to make the diagnosis. So this is called as tinea incognito. Now, the steroids are reducing the inflammation, but are they killing the fungus? No. So when you stop the steroids, what will happen? It will all come back. So this will recur on stopping the cream. This is very typical of tinea incognito. The redness and the itching will reduce when the patient is applying the steroid cream, but it will recur after stopping it. And many questions give us this complete clinical picture. So this will be very easy to make a diagnosis here. That is tinea incognito. You can't really make out the exact diagnosis. In such a patient, you stop the steroids, start the antifungals, and it will be treated. Now, coming to question number 4. Identify the lesions. This is like an often asked question in the FMG exam. If you open the last 5 years papers, you will see this question being asked at least 2 to 3 times. So around the anal cavity, around the anus here, what do we see? We see multiple skin-colored, 2 hyperpigmented papules which have a rough verrucous surface. So this is what you make out, and they are discrete as well as coalescent. So when you have such typical features around the anal cavity, what is this? I know these as genital warts. I can diagnose these as genital warts. Now let us look at the options. Condyloma acuminata, genital herpes, condyloma lata, and hemorrhoids. Now I know this as genital warts. So what is the correct answer amongst this? The correct answer here is option A, that is condyloma acuminata, because this is just another name of genital warts. Here you see these typical features of a wart, a rough verrucous surface. And the papules can be discrete as well as coalescent. Genital herpes will show vesicles, which are grouped together on a red base and they are painful. Condyloma lata, seen in secondary syphilis, again very different morphology. Hemorrhoids will be smooth skin-colored bumps that you see in the perianal area. So even by elimination, the correct answer here is option A, that is condyloma acuminata. How do you remember? See, A of acuminata is A of anogenital warts. So condyloma acuminata is just another name for anogenital warts. Acuminata on its own means pointed. So these warts tend to have a pointed tip. That is why they are called as condyloma acuminata. Most commonly caused by HPV-6. Otherwise, the two most common causes are 6-11. But if you have to know the most common, that is HPV-6. These can be present most commonly in the men around the frenulum and the coronal sulcus because they spread by autoinoculation. So these are the most trauma-prone areas in the men, and in the women on the posterior fourchae. So these are the most common sites for genital warts. Of course, they can also be present around the anal area, but the typical morphology remains the same. In treatment, we use an immune response modifier which is called as imiquimod, that is a toll-like receptor 7 agonist. Here, when you give imiquimod, it tends to increase the chances of the host immune response identifying the virus and killing it. So this is an immune response modifier. Then in genital warts in a pregnant patient, what is the treatment of choice? Cryotherapy. Second best treatment is the use of TCA, 70 to 90%. When you look at the other three options, let us see how they look like. Condyloma lata, as I just told you, is seen in secondary syphilis. Lata in itself means a flat lesion. So when you look here, these are flat topped papules and plaques, and they have a moist, oozy surface. So these have a moist, oozy surface, and these are flat topped lesions. In Hindi also, lata means leta hua. So the patient has flat lesions. These are seen in secondary syphilis, and these are the most infectious lesions of secondary syphilis. Condyloma lata. Then we have genital herpes, which is caused by HSV-2 most commonly. Here you see these grouped vesicles on a red base with bilateral painful inguinal lymphadenopathy. Hemorrhoids will be skin-colored swellings that you see in the perianal area. So very different from the clinical picture given in the exam, easy to make a diagnosis. STIs on their own are so important that in every exam there will be at least 1 or 2 questions from STIs. So you cannot absolutely ignore hair, STIs and psoriasis. There is no way that a question from these 3 topics will not be there in the exam. Now, coming to question number 5. A 3-year-old child presents with a generalized vesicular rash all over the body involving the trunk. His brother also has a similar rash. What is the diagnosis? So the question tells us that there is a child with a vesicular rash which is present on the trunk, and there is a family history. There is a brother suffering from a similar rash, which means that the disease is contagious, highly contagious. And what are the options here? Options are varicella, rubella, measles, and mumps. Now, a very easy diagnosis here. Why? Because the question tells us that there is a vesicular rash. So out of these 3, vesicular, V for V, remember, vesicular rash is only seen in varicella. Rubella, measles and mumps do not have a vesicular rash. So just by reading this one word of vesicular eruption, you can come to the diagnosis That is varicella. The two important vesicular rashes in the exam are number 1, varicella, and number 2, hand, foot, and mouth disease. In varicella, these are present on the trunk. In hand, foot, mouth disease, as the name suggests, on hand, foot, and the oral cavity. So these are the two most important viral rashes that have vesicles, especially for the FMG exam. On the other hand, rubella, measles, and mumps have maculopapular rashes, not fluid-filled vesicles. Now, talking a little more about varicella here, this is caused by the virus known as varicella zoster virus. The incubation period is about 10 to 14 days. Here, it is most commonly seen in children with a very high secondary attack rate of almost 90%. So mostly children in a family or a classroom may present together. So here in this patient, you have a low-grade fever. 1 to 2 days later, there is a generalized vesicular eruption all over the body, but it begins on the trunk and then it progresses to the distal extremities. So this is a rash that commonly starts on the trunk. This is why it is also called as a centripetal rash. When you look at it, these are all vesicles that you see. But not just vesicles. In this patient, we may see different stages of the rash together. There may be a papule, even the starting macule, papule, vesicle, ulcer. All of these can be present together at the same time in a patient. This is why the rash in varicella is also called as a polymorphic rash or a pleomorphic rash. So this is how a typical rash of varicella looks like, a pleomorphic rash. And when you look at the vesicle closely, you see that the vesicle is present on a red base, which looks like a dewdrop on a rose petal, giving it the typical name dewdrop on a rose petal appearance. Now, when we see at the other 3 rashes, see, rubella will have a typical reddish pink rash, which will be present over the body. So, rubella will be a typical reddish pink rash. Measles, on the other hand, will have a maculopapular rash, means there may be some areas which may be raised. Okay, so there will be a macule in the center of which there may be some papules. And typically in the measles rash, these lesions may coalesce, they may join together to form these blotches, which is why typically in measles the rash is called as a blotchy rash. So these macules and papules may coalesce together to form this kind of a blotchy rash. In mumps, yes, a faint red rash may be present on the body, but the most visible finding on the skin will actually be a swelling here that you see of the parotid gland, which is called as parotitis. So see, none of these has vesicles. None of this has a fluid-filled lesion. That is why these were eliminated. Now, if the question does not mention a vesicular rash, just fever with rash. So if the question says that the child has fever with rash and you have to choose between chickenpox and measles, what will you do? In chickenpox, the red rash will first start on the trunk and then it will spread to the body. And here, this rash is classically itchy, or pruritus is present with the rash in chickenpox. So this will start from the trunk, spread to the body, and here the lesions will be typically vesicles. In measles, the rash will start on the face. So this will start on the face and then it will spread to the body in a cephalocaudal pattern. Along with this, the patient may have conjunctivitis and a runny throat or a sore throat or a runny nose. Plus, if you look at the oral cavity, small white spots may be seen, which are called as complex spots. So the differences being, in measles, the rash will start from the face and the head, then spread to the rest of the body in a cephalocaudal pattern. Oral mucosa will show Koplik spots. On the body, the rash will be typically blotchy maculopapular rash. Plus, you will not see any fluid-filled lesions. You will not see any vesicles. So this is how you differentiate chickenpox from measles. Now coming to question number 6. A patient presents with hypopigmented lesion with loss of sensation. What is the diagnosis? So hypopigmented lesions can be multiple. Okay, hypopigmented lesions can be many lesions in dermatology. But when this lesion is associated with a sensory loss, then there is just one diagnosis. I don't even need to look at the options. There is just one diagnosis when a hypopigmented rash is associated with sensory loss, which is Hansen's, cutaneous TB, P. alba, P. versicolor. Yes, tell me what is the correct answer. Good. The correct answer is option A. That is the Hansen's disease. Because in dermatology, for your purpose, the only lesion that is associated with a sensory loss is leprosy, which is also called as Hansen's disease. Cutaneous tuberculosis generally does not even have hypopigmented lesions. On the other hand, Pityriasis alba and Pityriasis versicolor do have hypopigmented lesions, but they are very different and they are not associated with a sensory loss. So the correct answer for this question is option A, that is Hansen's disease. See, this is how it looks like. This is the cardinal feature of leprosy, to have a skin lesion which is hypopigmented and is associated with a sensory loss. See, leprosy is a primary infection of nerves. So the bacteria is present in the nerves. See, this is the nerve in which the bacteria is present. Now, when the body mounts an immune response, it is going to form granuloma around the nerve. It will kill the bacteria. Along with this, even the nerve is killed. So in the skin here, since the nerve is killed, you have a sensory loss, which is why typically a lesion of leprosy is associated with sensory loss. And in the surrounding area, you may also feel nerve enlargement. So this is how typically a case of leprosy looks like. On the other hand, when you have Pityriasis alba and Pityriasis versicolor, see how they look. Pityriasis means scaling. Alba means white. So here you see these hypopigmented lesions on the face of a child which are associated with fine scaling. So hypopigmented macules on the face of a child with fine scaling is how Pityriasis alba looks like. Pityriasis versicolor, again Pityriasis means scaling, versicolor means variety of colors. So here the patient can have both hypo or hyperpigmented scaly lesions, classically on the upper back and the upper chest. This is caused by a fungus called as malassezia. In fact, this was a question again asked in the 2021, one of the exams in 21. So Pityriasis alba is asked, Pityriasis versicolor is asked, and this time they are in the options. So what is the fungus that causes versicolor? It is malassezia. Okay, most commonly globosa, can also be caused by malassezia furfur. Here you have fine scaly hypopigmented or hyperpigmented macules on the upper back and the upper chest. So this is very different from leprosy and there is no sensory loss in these lesions. Now coming to question number 7. Which of the following deficiencies is associated with diarrhea, dermatitis, alopecia and poor wound healing? Deficiencies asked in almost every exam again. So these are some stat topics for the FMGE exam and you absolutely have to know them. One of these is the nutritional deficiencies. We are asked pellagra, we are asked acrodermatitis enteropathica. No way you cannot know them. Now tell me, what is this? The patient is suffering from diarrhea, dermatitis, alopecia, and poor wound healing. Niacin, zinc, magnesium, or vitamin E. What causes this clinical finding? If some of you have read D and D and you remember the triad of DDD, you may have ended up marking niacin, isn't it? Because you remember diarrhea and dermatitis, but no. You also have to notice that the patient is suffering from alopecia. So where is this triad of DAD seen? This is seen in deficiency of zinc, which is called as acrodermatitis enteropathica. See, this is acrodermatitis enteropathica. It is an autosomal recessive disorder where there is deficiency of zinc. And I always teach you the typical triad, that is DAD, diarrhea, alopecia, and dermatitis. Most commonly seen in infants after 6 months of age, where they suffer from diarrhea, alopecia, and dermatitis. The typical rash being an erosive rash on the face and the groin. Very important image-based questions, and now asked in the text also. So very different from the triad that you read in pellagra, which is DDD, the 3 Ds, which is diarrhea, dermatitis, dementia. This is seen in niacin deficiency, also called as pellagra, and the typical skin finding is Casel's necklace. So here the triad is DDD, 3 Ds. On the other hand, in acrodermatitis enteropathica, the triad is DAD, that is diarrhea, alopecia, dermatitis, along with poor wound healing is seen. So do not confuse between these two. Acrodermatitis enteropathica is DAD and pellagra is 3 Ds. If untreated, there is a 4th D called as death. And on the skin, the typical finding is Casel's necklace. Okay, so do not confuse between these two, and these two you should absolutely know. Now coming to question number 8. A patient with a history of burn 3 years back. That means it's an old burn. So patient with history of a burn 3 years back now presents with the skin condition as shown below. What is the diagnosis? So the only hint the text is giving us that the patient has an old burn scar. Now when you look at the image, you do see the burn scar. In the middle of the scar, you see an ulcer with exophytic granulation tissue. Now when you see an ulcer with an exophytic granulation tissue, you have to think of a malignancy. What malignancy develops in a burn scar? Melanoma? No, it will be black in color, not necessarily associated with a burn scar. SCC? Yes, can develop. BCC? Not in a scar, and this is not how a BCC looks like. Marginal ulcer? Definitely yes. Marginal ulcer is the malignancy that develops in a burn scar, and actually it's a type of SCC. So it's an SCC developing in a burn scar. But the best answer here will be marginal, because that's typically a malignancy that develops in a scar. Now, how do you know that this is a marginal ulcer? See, this is typically a malignancy which is developing in a scar. Scar could be due to any reason. It is not necessarily a burn scar. It could be any scar, which is an old scar. And here you develop an SCC. It can be like an ulcer here, or it can be an ulcer with exophytic granulation tissue. At the end of the day, it's a non-healing chronic ulcer in the scar. Marginal ulcer used to be a favorite image-based question 2015 to 20. Asked n number of times as an image. And now, of late, they have started asking different malignancies as well. Marginal ulcer has also made a comeback. So this is an SCC in a burn scar. About another image which has an ulcer, that's the rodent ulcer that you see in BCC. So this is the rodent ulcer that you see in BCC. But this ulcer typically has the rounded margins of a BCC. So you see these rounded or the rolled up borders which are typical of BCC. Along with that, when you see the edges here are classically undermined edges. So rodent ulcer is one of the causes of undermined edges. So it's very different from the image that was given in the exam, and it's not related to a burn scar. Then if you see the typical lesion of a BCC again, this is a pearly white, shiny lesion with telangiectasias, typical rolled up borders, and there may be a small erosion or a crusting in the lesion. And BCC will develop de novo. It does not have any pre-malignant condition. There are no scars needed. It is a chronic, slow-growing tumor which does not metastasize. So the BCC does not look like what was in the image there, and neither does the ulcerative form that is called as a rodent ulcer. So I hope this question is clear here. This patient who has developed a malignancy in a burn scar, the correct answer is Marjolin ulcer. Coming to question number 9, identify the condition. So what is the condition showing us? It is showing us a blackish brown lesion with irregular asymmetrical margins. So what we see here is a brownish black lesion with irregular margins which are asymmetrical. Okay, and when you look at the colors, here it is more black, here it is light brown, here it is very light brown. So what you see are multiple colors in this lesion. So when it is brownish black with irregular asymmetrical margins and it has multiple colors, what is the diagnosis? BCC we just saw does not look like this. Squamous cell carcinoma also does not look like this. Now we have to choose between melanoma and seborrheic keratosis. Seborrheic keratosis is also a brownish lesion, but it does not have the other features. These all features together when present give us a diagnosis of melanoma. So the diagnosis here is malignant melanoma, which is also the correct answer. Whenever you have a brownish black lesion and you have to see if it's a melanoma or developing a melanoma, you do the ABCDE assessment of melanoma. A stands for asymmetry. The lesion starts becoming asymmetrical. Then there are uneven borders, multiple colors, large diameter, and evolving changes. So this is called as the ABCDE assessment of melanoma. And whenever such changes are present, it makes us easy to take a hint that a melanoma is developing. We do a biopsy, confirm if there are malignant changes, and then we do the staging. After doing the staging, we start the treatment. So this is the typical protocol that we follow in these patients. See, how does it metastasize? By the lymphatic route. Most common type in the world is the superficial spreading type of melanoma, but in India, the most common type is an acral lentiginous melanoma. And how do you do the staging? The histopathological staging is done using the Breslau's criteria, where thickness less than 0.75 millimeter is a good prognosis. More than that is a poor prognosis. So the criteria, you have to remember the name, that is the Breslau thickness. And whenever an image shows a malignant melanoma, it will always be a black lesion. In fact, this was an image given in the August 2020 exam and asked one more time after that also. A black tumor on the skin is malignant melanoma for you all. Cannot go wrong in that. Now, about seborrheic keratosis, this is also a brown lesion, but how does it look? You see that this is a well-defined with regular margins. You have a brown lesion. This is a benign condition, generally develops due to sun exposure as the age progresses. But when there is a rapid increase in seborrheic keratosis all over the body, this may be a marker of a patient developing gastric adenocarcinoma. This is called as the Laser-Trillard sign. So remember the name of the sign? Laser-Trillard sign is rapid increase in seborrheic keratosis over the body in a patient who may be suffering from stomach cancer. Now, what are the other two skin findings, that may give you a hint that the patient is suffering from gastric adenocarcinoma? The other two that you have to remember are acanthosis nigricans and tripalms. These are two other conditions that may give you this. Now, Another question, which is also the last one, and I hope you all have got them right till now. So which system is involved in the following condition? Arterial, venous, lymphatic, or the neural? So what do you see in the image? In the image, you see that there is a gross swelling and disfigurement of the limb. So when there is such a gross swelling and disfigured limb, what is the diagnosis? The diagnosis here is elephantiasis, which is seen as an end stage of filariasis due to damage to the lymphatics and the lymph nodes, because of which there is a distal lymphedema. Lymphedema over a period of time can lead to such a gross swelling, limb hypertrophy, and disfigurement. Now, I have already told you what is involved. Lymphedema, that means this is involving the lymphatics. So the correct answer to question 10 here is lymphatics, because that is what is damaged in filariasis. With this, we finish our discussion of the July 23 derma questions. I hope you all got them right and will help you in crossing the magic figure of 120. And for all those who are yet to give the exam, you cannot not know these questions. Be very thorough with the PYQs. Any doubts, you can post them in the comments. All the best. Study hard.